easily identify most of the rhythms. But again, a word of caution, we are not making you an expert of ECG because that's the job of the cardiologist. But definitely we can make sure that you understand what are the lethal rhythms or what are the pre-cardiac arrest rhythm which you must identify and treat quickly so that you can prevent the cardiac arrest. To identify correctly, we are well aware about the conduction system of the heart. And when we talk about the conduction, we always divide into the heart into the two sections, not in the four chamber as we talk that there are two atria and two ventricles. So four chambers, we talk two, atrial and ventricular. And we know that it starts, all electrical activity of the heart, it starts from SA node, which is there in the right atrium. And from here, the electrical conduction initially through the internodal pathway goes to the right atrium itself and it causes depolarization, and then to the left atrium that causes the depolarization of the left atria, and finally it reaches to the at the AV node, and from AV node through the common bundle of His it reaches to the ventricular septum, and in the ventricular septum it divides into two, left and right bundle branch, and then left bundle branch again divides into left anterior and left posterior branch, and these right bundle branch and left anterior and posterior depolarizes the free wall of the ventricles. This is how it takes place. In the simplified manner, depolarization, when we talk, it is a contraction, and when we say repolarization, relaxation. And what happens, this is happening inside the heart. What happens on ECG strip, what we are looking from outside. So the first, any deflection, or deflection we see is the P wave. That is because of the depolarization of the atria. The first half of the P wave is made by the depolarization of the right atrium, and second half depends upon, this is because of the left atrial depolarization. And then comes a small interval, small delay, that's what we call it as PR interval, followed by, you can see, a Q wave, negative deflection, QRS complex, a positive deflection, and finally another negative deflection. So QRS. This is ventricular depolarization. And finally, we look at another wave which is on the positive side, that's called as T wave. So T wave denotes the repolarization of the ventricle. Okay, so this is how we look at the ECG. Besides this, we can have U wave, and when we look at ECG, besides these waves, we look at some intervals like a PR interval, QT interval, some segment we look at ST segment, and QRS duration, and RR interval. All these things are important in making an interpretation of ECG. So how do we, between the two R waves, are 300 divided by the number of large square between the two R waves. Yes, that's a very simple method, so it's accurate, calculation is pretty accurate. But as an ACLS provider, or the rate is less than 60, means it's a bradycardia, or the rate is more than 100, it means it is tachycardia. Whether it's 110 or 150 does not make a difference. So this is how it has been. It is calculated. So you don't need to count even the large square. You just need to see at two markers, and you count the number of R waves in that between those two markers. And if you are doing for 3 seconds, multiply it with 20. And if you are doing it for 6 seconds, multiply with 10. It is as simple as that to calculate. I will request anyone, if you have any doubt, please stop me right up there and you can ask question. Because if you understand these steps, ECG will become very easy for you to make any kinds of interpretation. So 3 seconds step, either you count 15 large square, or you look at the markers, count the number of R wave and multiply with 20. We can simplify it more. Between the two markers, you count the number of R wave. If the number of R wave is between 3 to 5, it means it is normal heart rate. If it is less than 3, it is bradycardia. If it is more than 5, it is tachycardia.
Perfect.
So this can be most simplified. You just look at ECG and you can tell that this is a tachycardia, bradycardia, or normal heart rate. So any of these methods can be done, and you can apply any of these methods. For example, if I look at, this is 3-second strip, you can see here, and I look at the R wave 1, 2, 3 and 4, means the heart rate is 80, or without calculating I can say it is between 3 to 5, it means heart rate is normal. If I make it 6-second strip like this, again I count 1, 2, 3, 4, 5, 6, 7, 8, I multiply with 10, it is 80. So any method you apply, you will get an idea about the heart rate, what is the range of the heart rate. And this is what is intent of making you understand that the heart rate calculation will tell you it's a bradycardia, normal heart rate, or it's a tachycardia. The next step we look at is the rhythm. We look at two things, whether the rhythm is regular or rhythm which is basically produced by contraction of the atria. So P wave, this is basically a first deviation from the isoelectric line, means the flat line, and it should be rounded and upright. You can see here, it is rounded and upright. And basically, it is generating from SNO. The first half is made by right atrial depolarization, and second half by left atrial depolarization. Now the first half is the going up and second half is coming down. This we should remember that any wave, because we are reading from outside, ECG is from outside, so any wave moving towards the reading lead will have a positive deflection, and any wave which is going away will have the negative deflection. So this pattern, if you are finding a P wave which is followed by QRS complex, that means it is a normal pattern where the conduction is taking place normally. So we have to look at 5 things when we talk about P wave. Whether the P wave is present or not. You are able to identify P wave in comfortably, that you look at ECG, okay fine, this is the P wave, whether it's a present or not, whether it is coming at a regular interval or not, and every P wave is followed by QRS complex or not, and every QRS complex is preceded by P wave or not. These two statements are different, you should always remember that. And what is the contour of the P wave? It's rounded, upright in appearance, or they are inverted. And then morphology of the P wave, that all P waves are looking similar or not. So simple to remember, P wave present or not, every P wave is followed by QRS complex or not, and what is the morphology of the P wave. If you remember these 3 things, you can simply identify a lot of ECGs. Then you look at PNR interval. What the PNR interval denotes? It's basically time interval from onset of atrial contraction to the onset of ventricular contraction. So starting from P wave to the onset of Q wave. So basically the normal duration is 0.1 to 2.2 seconds. So each small square on the horizontal axis, we look at the time. So it's a 0.04 second. So 3 small square will make 0.12 seconds and 5 will make 0.2 seconds. So this is the normal range. What you have to look at, whether the PR interval is more than 0.2 or not. Because looking at the smaller size of PR interval, that talks about the aberrant pathway, like a delta waves or other waves. So that's a bit complicated, but what is more important for you to look at the conduction blocks, AV conduction. So that if it is more than 0.2, then it is going to guide you that possibly there is an AV conduction problem. And third, all PR intervals are similar or not, because if it is a variable, this is again going to guide you about the blocks. Then last step, we look at QRS duration. Simple to remember, whether the QRS is narrow or QRS is complex. Narrow means less than 3 small square or 0.12 second. That's it. If it is wide, it means the conduction is ventricular, which we see normally in the ventricular tachycardia or other ventricular origin rhythms. But if it is narrow, it means it is sure that the conduction is happening from above the ventricle. So these are the 5 simple steps. If we go stepwise and we follow this practice, most of the ECG, especially during the ACLS or BLS, means the cardiac arrest situation, you can identify. So you just look at the QRS complex, whether it's a wide or it is narrow. Then comes the T wave. As I said, it is basically a ventricular repolarization, and sometimes you get a U wave after the T wave, which denotes the, normally it's non-pathogenic or non-pathological, or sometimes it is, we can see in the cases of hypokalemia. So how do we identify the rhythm? Let's take one by one. Anybody is interested, you can take the mic and you can identify this rhythm. Anybody? Anyone interested? You can try. Okay, how you say, if we go stepwise. One, we look at the heart rate. So how do we calculate the heart rate? What's the heart rate in this? You are right, your answer is absolutely correct. It's normal sinus rhythm. Can you take the mic so everybody can listen?
Sir, as the rhythm is regular, I'll go by the method.
Start from heart rate.
Okay.
Always make a habit. If you are missing any one step, possibly, maybe this time your diagnosis may be correct, but may not be correct all the time.
So 1500 divided by number of small scales between 2 RR intervals.
Okay.
So it will be, sir, approximately 100 beats per minute, sir.
Okay. So can you apply another rule what I said, 3 seconds? So 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15. So 1, 2, 3, 4, 5, you are right, it's 100. Perfect.
Yes.
Next. After rate, we look at rhythm.
Rhythm is regular, sir.
Regular, because RR interval is same. Wonderful. What next?
Sir, P wave.
Yeah. P wave. First answer, P wave present.
P wave is present, normal PR interval and normal
No, P wave present. We answer 3 questions at a minimum.
Okay.
1, P wave present. PQRS relation, is it 1:1?
Yes,
Every
sir.
P wave is followed by QRS complex?
Yes, QRS complex.
Absolutely correct. Then you look at third, what is the morphology of the P wave? Morphology looks similar. We look at this P
similar
wave,
morphology.
this P wave, all are similar. Okay. Then what next? We look at PR interval.
PR interval.
So is it normal?
1. Yes, sir.
Yeah,
Normal.
PR looks normal. What about QRS complex?
QRS complex is normal, narrow QRS
It's
complex.
narrow. Narrow or wide, only 2 things we have to see, whether it's a narrow or wide. So it looks narrow because
Narrow.
it's less than 3 small square. So now your answer, now you can justify your answer, it is normal sinus. Can we clap for her? Great. So there is another step. Oh, sorry. So can anybody wants to try? Anybody? No? So if I look at this ECG, everything is similar, except that the distance is long between the RR intervals. So now I count this between these 1, 2, 3, 4, 5, 6. So it is more than 5. So it means if I look at the 15 large square, the number is less than 3 of R waves. So it means it's a bradycardia. Rest, everything is same because we can see the P wave. That means conduction is starting from S node because P wave morphology is similar. It is PR interval is same. So conduction is taking place normally. There is no block. And then we look at the QRS complex. It's a narrow. It means the conduction is generating from atria and it is reaching to ventricle and depolarizing in a normal fashion. Right? Except that the heart rate is slow. So we call it as sinus bradycardia. Please, thank you. Then comes this. If I look at this, again if I count, so it's coming 6 R waves in 15 common larger squares. So that means it is making it around 120. Rest all same because P wave is morphology is present, morphology is normal, PQRS relation is 1:1, PR interval is normal and QRS complex is narrow. So this is sinus tachycardia. So if we follow this, we can identify any kind of rhythm. We'll see in the subsequent slide. So arrhythmias, what we read is the arrhythmia, because we cannot label when there is a narrow complex arrhythmia, we call it as supraventricular. It can be sinus tachycardia, it can be atrial fibrillation, it can be atrial flutter, it can be supraventricular tachycardia. It's the sinus tachycardia. Our atrial fibrillation, very common arrhythmias, especially in the older age population, are premature ventricular contractions. So what makes us worry? Are you really worried about the arrhythmias? Yes, we are worried because we don't look at the ECG. ECG we are not seeing every time. But what we are worried about the cardiac output of the patient. We are worried about the myocardial oxygen supply and demand imbalance. Why? Because there will be reduction in the diastolic fluid time, coronary perfusion will be compromised and your patient will have myocardial ischemia. And if there is no P wave, then there will be loss of atrial kick, which contributes almost 15 to 20% of cardiac output. And ultimately, the tissue oxygenation will compromise and oxidative metabolism will be anaerobic metabolism. Now, all arrhythmias are an emergency, dire emergency? No. We have to look whether it's a lethal arrhythmia or non-lethal arrhythmias, but your patient should be very quick on these non-lethal arrhythmias because anytime they can degenerate to the lethal arrhythmias. So what are these? If we look at the lethal arrhythmias, life-threatening. Ventricular fibrillation, pulseless ventricular tachycardia, pulseless electrical activity, and asystole. Can anybody tell me what is the difference between these four? Can we divide into certain groups? Excellent. These two are shockable rhythm, ventricular fibrillation, and pulseless ventricular tachycardia. And pulseless electrical activity and asystole are non-shockable rhythm, where we continue with the CPR along with the other management. So whenever you come across with these patients, assess the patient. That's the rule of thumb. Assess the patient first. Identify the rhythm. Continue with a high quality CPR. Rapid defibrillation if it's a shockable one. Medications, whatever is required, depending upon the treating, your adrenaline, or if it's a ventricular fibrillation persistent, amiodarone, and then look at the reversible causes and treat those reversible causes. Until you do it, your patient will not be revived in spite of your high quality CPR. So these two are shockable rhythm. Now, if I follow the steps of identifying ECG here, how we can label this, how we can label this. Anybody wants to comment on this? No. Fine. So if I look at this ECG, rate, what could be the rate? If I look at these complexes, rate must be 300 or more than that, maybe 500. I cannot calculate the rate. Rhythm, irregular. I cannot comment on the rhythm because I am not able to identify any R wave. P wave, I can't identify the P wave. QRS complex. So if I can't identify, I cannot comment on the PQRS relation. I cannot comment on the morphology of the P wave. Then I cannot comment on the PR interval. If I look at the QRS complex, certain complexes are there, but they are very chaotic. So any chaotic wave which is having a wavy pattern up and down from the baseline without identifiable rhythm is called as ventricular fibrillation. If I look at this ECG, so here almost everything is similar, but wide complexes are identifiable, and we can count the rate of these wide complexes. That's why this is ventricular tachycardia. So this is how we can identify any rhythm. Then non-shockable rhythm. What is difference between the pulseless electrical activity and normal sinus rhythm? ECG complexes may be similar, but there will not be any pulse in cases of pulseless electrical activity. So this is very, very important, and that's why it is very important you assess the patient first before looking at rhythm. Because if you look at this rhythm, you will say it's a normal sinus rhythm. But if the patient is not having pulse, this becomes the pulseless electrical activity. Non-lethal arrhythmias, these are very common, much more common, can be divided as a tachyarrhythmias when the heart rate is more than 150. Normally we say tachycardia when heart rate is more than 100. But patient becomes symptomatic only when his heart rate goes above 150. Similarly, we label bradycardia when the heart rate is less than 60, but usually patient becomes symptomatic when heart rate goes below 50. So again, you have to assess the severity on the basis of symptoms and signs, because these are the patients who will be coming to you with certain complaints. They are conscious, but they can complain that possibly I have lightheadedness, I'm having shortness of breath, ongoing chest pain, I'm having chest pain off and on, or there are palpitation, धड़कन बढ़ी हुई है, काफी बार पेशेंट की कंप्लेन होती है, और family tells he was fine in the morning, but in the afternoon he has become drowsier, or he has become irritable. Initially he was drowsy, now he has become irritable. So all these basically are suggestive of hypoperfusionistic phase. So to assess this, we look at certain signs of shock, hypotension, certain ECG changes, and we look at the diagnosing the acute heart failure. How do we do this? We look at blood pressure. If the systolic blood pressure is less than 90, it means patient is having hypotension. If the patient is having pallor, sweating, cold and clammy extremities, that means he is in shock. Altered mental status, are losing consciousness, are getting irritable, possibly cerebral blood flow is compromising as reduced, and that is leading to altered mental status. And we look at, auscultate the patient, and we found that there is a bilateral basal crepitations, or if you look at the JVP is raised. And signs of myocardial ischemia, you will find that there are frequent VPCs, or there is a ST depression when you look at ECG. So this is how you assess the patient. And when you assess the patient, and when all signs or any one sign is present, that means your patient is unstable and needs immediate intervention. If symptoms are present but no sign present, it means patient is stable. You can assess the patient, you can get ECG done, and you will look for expert opinion. But any of these things are present, it means your patient is unstable and needs immediate intervention. So what we should do, whether it's a tachyarrhythmia or bradyarrhythmia, we have to look for whether patient is stable or unstable. So if signs are present, it means patient is unstable. So we should try to stabilize the patient, and we should answer two questions. Whether the symptoms and signs are due to arrhythmia itself, or there are some other underlying cause. I give you a very simple example. Suppose a person is having a fever of 105 and he is having a heart rate of 150. So whether the symptoms are signs due to the patient is complaining, बहुत घबराहट हो रही है, पसीना भी छूट रहा है. So symptoms and signs are due to arrhythmia, or there is some other underlying cause. Yes. Fever 105, heart rate 150. Tachycardia, sinus tachycardia. Because of fever, it's as simple as that. Because if you have a fever, you are going to have a tachycardia. So this means the symptoms and signs are not because of arrhythmia. There is some other underlying cause, and that causes fever. And you look for why the patient is having fever, probably having some septic focus, and that has to be addressed. So this is important that you look for underlying cause, and treating the underlying cause is always a priority. Besides maintaining your patient, managing patient's arrhythmia, it is important to treat the underlying cause. If you don't treat it, patient will never improve. So if at this tachycardia, suppose in the ICUs, what we so many times we see, patient is having septic shock, patient is having heart rate 160. Do we try to treat it? Never. If you try to treat it, patient will collapse immediately. Because the patient's cardiac output is maintained on the tachycardia because of very high cardiac output in cases of septic shock. So he will die immediately if you try to reduce this heart rate. So this is important that you treat underlying cause. So our approach, what should be? If the patient is unstable, means patient is having certain signs, symptoms, and when we examine, we found that there are signs also. So if the patient is unstable, our intervention should be quick, by pharmacological means, by electrical means, and we should always seek for expert opinion. And if the patient is stable, keep monitoring the patient, get a 12-lead ECG done, because you have a time now to think that what the different diagnosis can be made on this, and then you look for expert opinion. So this is why it is important as an ACLS provider, we must be able to differentiate between the stable and unstable tachyarrhythmias or bradyarrhythmias. There can be AV block, it can be incomplete, first degree or second degree type 1 and second degree type 2, or complete heart block or third degree AV block, or there can be junction rhythm as well. So can anybody wants to comment on this ECG? It's better if we have a two-way communication. First one. Anybody? Same rule. Starting from rate, rhythm, P wave. First ECG. Anybody wants to comment? Second degree. Which time? Type 1. Great. Can we clap for it? Very good. How you justify? Starting from rate. Make it a habit. Whenever we are reading ECG, we should start from basics. Rate. So we start counting the large boxes 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14. So around rate is around 78, 60, 70. Okay. Rhythm? Irregular. P wave. Excellent. This is the first two abnormality. First abnormality was rhythm is irregular. Second abnormality, P wave is not followed by QRS complex. Certain P wave. So what is more? P waves are more. So what is happening now in the heart? Just think over it. P wave is generating from SA node, but it is not conducting to the ventricle, and that's why it is not producing the QRS complex. And this is what the abnormality, what we call it as AV conduction block. Right? Very good. What next? Excellent. So progressive lengthening of PR interval followed by misbeat, and that's a suggestive of second degree type 1. Excellent. So similarly, if you look at this ECG, everything is same except that PR interval is fixed. So what we call it as second degree type 2 block. This, if you look at, this is the distance between the PP interval and RR interval is same, and that's suggestive of complete heart block, because there is totally chaotic. P wave is coming off its own, QRS complex is coming off its own. There is no integration between the P wave and QRS complex. And anybody wants to comment on this, the last ECG? What was the last ECG? Anybody from the back? So what is abnormality here? Let's talk about abnormality. What is abnormality here? Inverted P wave. So why it is inverted? What does inverted P wave signify? It means conduction is happening on the opposite side. And it means from where it is generating. Not from SA node. From what are the other area of conduction generation? It can be AV node. So any wave which is generating from AV node is called as junctional rhythm. So it is possible that the P wave is inverted. Sometimes P wave will be absent, or sometimes you will find that the P wave is coming after the QRS complex because of retrograde conduction. So all three possibilities, this is the junctional rhythm. And the second abnormality, if you look closely to the ECG, PR interval will be short. So it means if a wave has to start from SA node to the AV node, it will take certain time. But if the wave is just starting from AV node, it will reach very quickly to the ventricle. And that's why the PR interval is short. So if you look at the different degree of AV blocks, it is very simple to degree AV block. There is a prolongation of PR interval more than 0.2 seconds. The problem comes when we look at the second degree type 1, second degree type 2 and complete heart. So there is a simple method. How do we identify? We look at the block when we say P waves are more than QRS complex. So in all three, we see P waves are more than QRS complex. The second, how we differentiate between these three, we look at RR interval. So if the RR interval is regular, as we see in the complete heart block, this is complete heart block. PP interval and RR interval will remain the same, right? Then we look at, so that this is excluded. Now differentiation between these two, we look at PR interval. If the PR interval is fixed, it is second degree type 2 block, and if there is a progressive lengthening of PR interval followed by a drop beat, it means it is a second degree type 1 block. So this is the most simplified method we can differentiate between the different kinds of AV blocks. So how do we manage? We correct the underlying cause. For these any bradyarrhythmias, suppose patient is hypothermic, we correct the temperature. We administer atropine. Transcutaneous spacer can be used if it is available, but you must know that the difference between the electrical captures and the mechanical capture, what we look for electrical mechanical capture, that should always be achieved. Or you can start dopamine infusion at 2 microgram per kg per minute or adrenaline infusion at 2 microgram per minute. And you should always look for expert opinion, and ultimately you have to look for transvenous pacing, because transcutaneous spacer is a painful procedure, so you can't continue it for a longer time. There are certain conditions even when the patient is stable, still you need a standby pacing, and these three conditions are asymptomatic movements type 2, second degree type 2 block, any asymptomatic third degree AV block, or any newly acquired alternating bundle branch block. Suppose you look at ECG at 2 p.m., it was right bundle branch block, and when you look at 4 o'clock, it was left bundle branch. It means there is an alteration in the bundle branch block, and these all three conditions are actually suggestive of acute coronary event. So here you must have standby pacing for these kinds of patients. Coming on the tachyarrhythmias, Any rate more than 100 will be a tachyarrhythmia. Say sinus tachycardia, atrial fibrillation, supraventricular tachycardia, ventricular tachycardia, multifocal atrial tachycardia, junctional tachycardia. So any rate more than 100 is tachycardia, and this is atrial flutter. If I look at the rate more than 100, rhythm regular, P wave difficult to identify. P wave is replaced by some sawtooth pattern, and that's the classic of atrial flutter. What is this ECG? Anybody? This ECG? Anyone? Very simple. P wave दिख रही? नहीं दिख रही है. QRS complex दिख रहे हैं? दिख रहे हैं. Wide है. तो कहाँ से origin हो रही है? Ventricle. So heart rate more than 100 है. तो क्या कहेंगे इसको? Ventricular tachycardia. So this is how we need to learn to identify ECG. What is this? The P wave is replaced by some fibrillatory waves with a irregular rhythm. So this is classic of atrial fibrillation. Why I am saying this is atrial? Because all these are narrow complexes. Why I am saying this ventricle? Because it's a wide complex. What is this? So here the abnormality, if I look, P wave is of different shape and size, and PR interval is variable. So what does this signify? It means there are various focus in the atria which is generating the P wave, not only the SA node but other areas. So, and the heart rate is more than 100. QRS complex is narrow. So if QRS complex is narrow, it is any kind of tachycardia, means it's coming from above ventricle. From where it is coming? Because there is P wave, so it means it is being generated from atria, and because it's a different shape and size of the P wave with a different PR interval, it means there are multiple focus in the atria which is generating the wave, and what we call it as multifocal atrial tachycardia. What is this? Because here QRS complex is narrow, but we are not identify any P wave. We are not able to identify. So what is it? What we call it as? PSVT. Why we will PSVT? We will say SVT. If there are paroxysm, means complexes, there is a tachycardia followed by some P wave QRS complex normal sinus rhythm pattern. Then we call it as paroxysm. But when we look at this ECG, we call it as supraventricular, because we are not able to identify the origin from where it is originating. But I am 100% sure it's tachycardia and generating above the ventricle because it's a narrow complex. QRS complex is narrow. So this is supraventricular tachycardia. So how do we manage? Again, we look at the underlying cause, we try to treat that. Cardioversion is the solution here. As we talk the transcription spacer, cardioversion is the solution here if the patient is hemodynamically unstable. The selection of energy will be different. For atrial flutter, it will be 50 joule. Atrial fibrillation, it will be starting from 100 joule. Monomorphic ventricular tachycardia, 50 joule, and you can escalate to 100 joule. And if time permits, you can always look at the lead ECG so that you can differentiate whether it's a wide complex tachycardia or it's a narrow complex tachycardia, and rhythm is regular or irregular. So if it is the regular one, we can try adenosine, we can do a carotid sinus massage, and we can use antiarrhythmic agent in the form of amiodarone, beta blockers, or calcium channel blocker. If it is the wide complex regular tachycardia, you can give one dose of adenosine, but usually do not respond. You need to give antiarrhythmic drugs. So anybody wants to comment on this ECG after listening all the talk? So what you will do? Sister, help! Patient की lead उतर गई. And this is the real story in my hospital. I'm talking in 2002. We trained our staff for CPR, a lot of enthusiastic CPR staff in ICU. So one fine day, a sister jumped on bed and started doing chest compression. And Baba जोर से चिल्लाए, क्या कर रही है मेरी छाती पे चढ़ के? This is a real story. So this is why we say assess the patient first. If you don't assess, this kind of a thing can happen. Thank you very much. Just to conclude, identify early because probably you can prevent the cardiac arrest. So pre-cardiac arrest rhythm must be identified and addressed at the earliest. Always assess the patient and interpret patient with the rhythm, not rhythm alone. Take appropriate measure to prevent the worsening of your patient and appropriately react to the life-threatening arrhythmia. It's shockable, shock CPR, non-shockable, only CPR. And always look for the underlying cause and treat the underlying cause. Thank you very much. I'll be happy to answer if there is any question. No question?
Thank you, sir, for such an informative lecture. Now it has become much easier to decode ECGs. Moving forward,